Good morning, everybody. Thank you, Dr. Gupta sir, Dr. Vikas, Dr. Anand for inviting me here. I must say that it's going to be quite brief. When I started researching for this particular topic, I was a little surprised at the almost lack of big studies. Though we know that head and neck cancer is a major issue in India, there were hardly any studies from India, and even overseas, the studies are very, very small in number. So my topic is dysphagia in head and neck cancers, and we know dysphagia is a very common symptom in head and neck cancers. It's either related to active treatment or the disease-related issues. Basically, disrupted swallowing mechanism, it can cause silent or sometimes even overt aspiration in 2/3 of patients with advanced head and neck cancers during the first year of treatment, and almost 25% suffer from decreased swallowing function even up to 5 years post-treatment. Now, this is definitely going to affect their overall well-being, nutritional well-being and quality of life. So again, in spite of this being such a common problem, we really don't have big studies to address this issue. We know the causes of dysphagia. It could be surgical procedures involving the oral cavity and oropharynx, or sometimes post-radiotherapy fibrosis of the irradiated tissue, impaired movement of the oral tongue, tongue base, pharyngeal constrictors, larynx, salivation-related issues, cervicofacial or pharyngolaryngeal lymphedema, absence of taste and mucositis, poor saliva. All these things can produce dysphagia. In fact, while reading for this topic, I came to know that there is a separate journal which deals only with dysphagia. Now, how important is nutrition? Well, we've been hearing about nutrition since morning, and again, there is very little randomized evidence, but there is some retrospective data to suggest that patients who were treated with the standard TPF regime, docetaxel, cisplatin, 5-FU, had higher risks of grade 3 or more infections for weight loss at diagnosis, and people who required a feeding tube at diagnosis. There was also a higher risk of grade 3 neutropenia. That is understandable. We all know the physiology behind it. But point to be noted that if you have a nutritionally compromised patient who, because of his dysphagia, he is not able to eat, you are going to have more problems on chemotherapy. Another study from India, this is from Kolkata, they showed that there was an increased risk of nausea, vomiting, diarrhea, and stomatitis and tinnitus, paresthesia, all the adverse effects of cisplatin in patients with a lower body mass index. Another prospective study of head and neck cancers, these patients, those who had cachexia at diagnosis versus those who did not have cachexia at diagnosis, and you can see the difference between their disease-free survival is really stark. 13 months of disease-free survival for patients who are cachectic at diagnosis compared to 66 months, more than 5 times the difference in survival in patients who are non-cachectic. The curves are wide apart. The hazard ratio is 2.8. So how do we tackle this problem of dysphagia? During treatment, active treatment, when there is surgery happening, when there is chemoradiation happening, we all know that most of these patients are put in a nasogastric tube or a percutaneous endoscopic gastrostomy tube. Now, these are temporary measures. These are commonly employed measures. During surgery, many patients undergo a nasogastric tube feeding, and for chemoradiation, we try to push in a PEG tube. But I'm sorry to say that even in our practices, we find that most of the patients refuse both these options, and they stick to their oral feeding as well as much as they can do. Prophylactic PEG tube is inserted before starting the treatment, and a reactive PEG tube is inserted only when it's required, when the patient's nutrition starts suffering. Now, there is an interesting meta-analysis of 13 studies over 1,600 patients. They compared all these 3 methods, published about 3 years ago. Both prophylactic PEG as well as nasogastric tube were superior to reactive PEG tube. So you should be looking at the patient's nutrition and thinking of tackling this problem of dysphagia before the patient actively goes on treatment. And this helped in managing their weight loss. A prophylactic PEG tube was associated with the least rate of treatment interruptions. We all know how important these treatment gaps can be. If you have treatment interruptions on radiation therapy, it's going to affect adversely, and the outcome is going to be compromised. Nutrition related hospital admissions are also common in patients because they have if they are nutritionally compromised, they are going to have more chemotherapy related toxicity. All these factors were the lowest with a prophylactic PEG tube. there was no difference in the tube-related complications. So that fear that an invasive procedure is going to be done, a PEG tube is going to be put in, which will have some kind of invasion, this may bring about some complications. This fear has also been put to rest. There is no difference in tube-related complications. So they recommend that a prophylactically inserted PEG tube may be a better choice in patients who are malnourished or who are going to undergo aggressive management for their head and neck cancer. Now this is for treatment-related feeding, but what about interventions pre and post-treatment? There is something very interesting which I found on the net, that if you increase the thickness of feeds, then that facilitates swallowing. So it shouldn't be a solid food bolus, it shouldn't be a liquid, completely liquid stuff. It should be something like a semi-solid, so it easily goes down the hatch and the chances of aspiration are less. Now, post-radiation, post-surgery, post-chemotherapy, intensive chemotherapy, there could be a reduction in the peripheral sensory input. This can affect the oropharyngeal swallowing mechanism. So there was this study of 51 patients who were treated for head and neck cancer with chemoradiation or surgery, and they were randomized to receive sour, sweet or salty bolus flavor. And the sour flavor significantly shortened pharyngeal transit time. So if you have a sour element in the food stuff, it will probably be swallowed easily compared to a sweet or a salty bolus. Exercises, the Masako maneuver, which strengthens the tongue, pharyngeal squeeze exercises, or repeated swallowing. Many of these patients who have bad mucositis or who have problems in their oropharynx just don't swallow, and they are dependent on the tube. Now, these repeated swallowing attempts also bring about strengthening of oropharyngeal muscles. There was a randomized study which evaluated these two approaches. Again, very small studies. All of these studies are small, 50 patients, 100 patients. This study had, they had two arms. One was given a formal exercise program of these Masako exercises and pharyngeal squeeze exercises, and the other was just given their standard care. The exercise group had less PEG tube immediately post-treatment. So even after treatment, their swallowing resumed normal. Within 3 months, they came back to normal oral feeds compared to the swallow group. Sorry. Another study randomized, again, 50 patients, early post-operative exercises versus standard swallowing practice. The exercise group received instructions regarding oral exercise and standard care, and standard group was just given the regular swallowing. The oral exercises had range of motion exercises of lips, jaw and the tongue, and resistance exercises for the tongue. And you can see the difference. The top line or the green line denotes the improvement in pharyngeal residue, and it is much better. There is hardly any residue. When you have the residue goes down easily as if you have given pre-operative, pre-intervention exercises compared to those who have a standard practice. Additional, if the patient doesn't want to do something, then we have to do something. So there was this small study, again, just about 14 patients, a prospective randomized study to see the effect of neuromuscular electrical stimulation and 30 minutes of traditional swallowing training. And again, very small numbers, 12 patients were randomized to sham stimulation plus traditional swallowing. So total not more than 30 patients. And the effects were assessed with various dysphagia scales, clinical dysphagia scale, the functional dysphagia, and many of these. But long story short, the pre-treatment evaluation, there was no significant difference. The average changes of the functional dysphagia were slightly better for the experimental group. But overall, the outcome was not statistically significant. But again, you are looking at a population of just about 26, 27 patients. So maybe if we have bigger numbers, we'll probably get better studies and this. So to summarize, dysphagia is an important adverse effect of treatment of head and neck cancer, and it has a profound impact on nutrition and subsequent quality of life. Tube feeding in the form of NGT or a PEG tube can be a temporary option during treatment, but the quality of feeds which you send down these tubes is going to be definitely compromised. So it's always better for the patient to come back to his normal feeding. Exercise initiated early in the post-operative period are helpful in establishing swallowing early in the post-treatment period. Thank you.